Welcome and thank you for attending my presentation entitled TissueCypher Objectively Risk Stratifies Barrett's Patients with Low-Grade Dysplasia. These are my disclosures. Risk stratification in Barrett surveillance is based on the histological diagnosis of surveillance biopsies by pathologists. So currently, low-grade dysplasia is our best predictor of malignant progression. However, diagnosing LGD in Barrett is challenging because there's a high intra-observer variability for the histological diagnosis of LGD. So current guidelines recommend that every LGD biopsy should be reviewed by an expert pathologist. Because LGD is overdiagnosed in 50 to 75% of the community-based diagnosis. And such overdiagnosed cases do not have an increased risk for malignant progression. And this is in contrast to the confirmed LGD cases, which carry a 5 to 10% annual risk for progression. So we can clearly see that there are several problems with pathology review of LGD cases. First, it is unclear what defines an expert pathologist. Second, access to expert pathologists is not widely available. And third, there are still logistical challenges in transferring slides for such review. So we all agree that there's a compelling need for an objective and easily accessible tool. So TissueCypher Barrett's esophagus assay is a commercially available, objective, precision medicine tool for patients with Barrett's esophagus. It's an automated assay of 4 standard histology slides and includes automated labeling and imaging for multiple immunofluorescence markers and nuclei. There's a fully automated computational pathology approach to quantification of the 9 protein-based biomarkers and their nuclear morphology. But how does TissueCypher exactly work? First, 4 or 5 micron sections from standard Barrett's biopsies are cut. So 4 slides for immunofluorescence staining, so 4 biomarkers per slide, including controls. Second, these slides are digitalized using whole slide fluorescence scanning. In a third step, an algorithm automatically identifies 15 predefined features. And these 15 features are again weighted automatically, resulting in a score ranging from 0 to 10. So based on an individual risk score, Barrett's patients are risk stratified into either low, intermediate, or high risk for progression to cancer within the next 5 years. TissueCypher has been extensively studied. There are now 5 peer-reviewed publications in high-impact journals over the last 5 years, all of them showing that TissueCypher can predict malignant progression in Barrett's biopsies. However, these were mainly case control studies, and with the exception of the last publication, TissueCypher was not yet studied in a true cohort study. Additionally, TissueCypher was not yet specifically studied for its value in LGD cases, but mainly in non-dysplastic cases. So the aim of the current study was to evaluate the predictive value of TissueCypher in a cohort of 155 Barrett's patients with a community-based diagnosis of LGD. And second, to benchmark its performance against a panel of 12 pathologists from the Netherlands and the US, including pathologists with a track record as expert Barrett's pathologists. So for this current study, we used 155 Barrett's patients with low-grade dysplasia. This cohort was derived from the screening cohort of the SURF trial, an RCT comparing surveillance versus RFA for confirmed LGD cases. So we used all the biopsies of the so-called baseline low-grade dysplasia endoscopy. Therefore, first 5 micron slides were cut and assessed by TissueCypher. Second, so-called sandwich slides, so slides next to the one assessed by TissueCypher, were digitized for pathology revision. For the pathologists, we cut 2 NH&E slides and 1 P53 slide. Finally, the worst biopsy score per endoscopy was used as an outcome for both TissueCypher and the pathologists. All biopsies were reviewed by a total of 12 pathologists. On the one hand, we had 6 expert pathologists, 3 from the Netherlands and 3 from the US. These expert pathologists do have a special interest in the fields of Barrett's for over 10 years. They have a minimum caseload of 5 to 10 mainly dysplastic cases per week and have co-authored more than 10 peer-reviewed publications in the field of Barrett's. All of them are actively involved in pathology training in the field of Barrett's. On the other hand, we had 6 community-based pathologists, again 3 from the Netherlands and 3 from the US. These 6 community-based pathologists usually refer dysplastic cases to an expert pathologist. 79% of the included 155 patients were male with a median age of 62 years and a median Barrett's length of C3 and 4. During a median follow-up of 7 years, these patients received a mean number of 3 endoscopies. 25 out of the 155 patients developed either high-grade dysplasia or cancer within the next 5 years, the so-called progressors. On the other hand, 130 patients did not progress to cancer within 5 years, the so-called non-progressors. This table illustrates the outcome of pathology review in the baseline biopsies. On the left, you see the 3 possible revision diagnoses: non-dysplastic, indefinite, and LGD in percentages. On the top, you see the pathologists grouped by both experience and origin. We can clearly see that pathologists downstage the majority of cases to non-dysplastic, with about 1/5 of the cases having confirmed low-grade dysplasia. Downstaged cases had a significantly lower progression rate, whereas confirmed cases progressed in 40 to 50% over the next 5 years. And this fact illustrates the relevance of a dedicated pathology review of community-based LGD cases. However, both experts and community-based pathologists scored a significant subset of cases as indefinite for dysplasia, and these cases had hardly a different progression rate than those downstage to non-dysplastic. So a logical next question is, do expert pathologists do a better job than community-based pathologists? Due to the following 3 reasons, probably yes. First, pathologists do more often downstage to non-dysplastic compared with community-based pathologists with similar low progression rates. Second, experts were less likely to diagnose indefinite with 11% compared with 25% in community-based pathologists. Third, experts do have a lower variability in their scores. This is demonstrated by a range from 52 to 82% in the cases downstage to non-dysplastics by the expert pathologists, compared with a range from 12 to 72% in the community-based pathologists. But how did TissueCypher perform here? TissueCypher downstage the majority of community-based LGD cases, so in 71%. And patients with a low TissueCypher score had a low rate of progression to high-grade dysplasia or cancer of 7.3%. On the other hand, patients with an intermediate or high-risk TissueCypher score had a similar high rate of progression to cancer. So as TissueCypher identified 17 out of 25 progressors, this resulted in a sensitivity of 68%. On the other hand, TissueCypher correctly downstaged 102 out of the 130 non-progressors, resulting in a specificity of 78.5%. But how does this compare to the pathologist's performance? So this depends a little bit on where we put the indefinite of the pathologists. If we group low-grade dysplasia and indefinite, as it is generally done in daily practice, we end up with a sensitivity of 67% and a specificity of 65% for the pathologists. On the other hand, if we group the indefinites with the non-dysplastic ones, which closely reflect their progression rate in our study, we end up with a sensitivity of 52% and a specificity of 85% for the pathologists. So this looks pretty good for TissueCypher. However, these results for the pathologists are the mean and the ranges from the 12 pathologists. To improve the visualization of our results, we do have here an ROC plot, in which the sensitivity is on the vertical axis and 1 minus specificity is on the horizontal axis. So this means that the best performing test is close to the upper left corner, as demonstrated by this circle here. So here are the results of TissueCypher represented by the green dots, the results of the expert pathologists in red and the community-based pathologists in blue if we group low-grade dysplasia and indefinite for dysplasia. And here's exactly the same plot, but now the indefinites grouped with the non-dysplastics. So we can conclude that in both instances, TissueCypher seems to be the best performer. And please note that the blue and the red dots, so the expert and community-based pathologists, do have a significant variability, and only the best performing pathologist comes close to TissueCypher. So in conclusion, our study is the largest cohort study in community-based low-grade dysplasia in Barrett's. Our data again show the relevance of a dedicated review of this diagnosis, because the majority of cases will be downstaged to non-dysplastic, and it identifies a subgroup of patients with a high risk of progression. Conventional pathology review, however, has some significant limitations. First, expert pathology is poorly defined and not widely available. Second, review is subjective and variable, even among the expert pathologists. And third, a significant subgroup is classified as indefinite for dysplasia, which reflects a non-conclusive diagnosis. So this study adds to the current evidence that TissueCypher is a much more logical tool for risk stratifying Barrett's patients, and in particularly those with low-grade dysplasia. Because TissueCypher is fully automated, it's objective, highly reproducible, and widely available. And it outperforms most pathologists and is as good as the best performing expert pathologist we could find for this study. Thank you for your attention.